This is Dr. Wendie Berg. This presentation complements a review article published in the AJR in September of 2020 on screening algorithms in dense breasts. There's also complementary material on the website densebreast-info.org. I hope you enjoy the presentation. We know mammography reduces deaths due to breast cancer by about 40%, but unfortunately it does not help every woman equally. If you are among the 40% of women who have dense breasts, your cancer, if present, may not be seen on mammography, and you may need additional screening. High-risk women in particular definitely need additional screening regardless of breast density. About 1 in 8 women will develop breast cancer in their lifetime, as few as 1 in 12 if there are no known risk factors, but as many as 1 in 2 if there's a strong family history or other risk factors. We do want to start screening with mammography at age 40 or 45 or 50, depending on which guideline you follow, but the greatest reduction in deaths occurs if we start screening all women at least by age 40, and it's particularly important to start screening by age 40 in Hispanic, Asian, and Black women, where there is an earlier incidence and peak age at breast cancer. It's also important to start screening high-risk women as early as age 25 or at least by age 30. This is a nice graph that shows the earlier onset of breast cancer and peak actually in the late 40s among women who are Black, Hispanic, or Asian, whereas the peak in Caucasian women is actually in the mid to late 50s. Unfortunately, even at this time, women still die from breast cancer. The majority of deaths in a series from the Partners Organization associated with Mass General and other hospitals in Boston found that 71% of breast cancer deaths were among women who did not participate in screening at all. And in fact, the median age at diagnosis of breast cancer among those who died was in the 40s. So we do want to start screening early, at least by age 40, and we want to encourage participation in screening every year in the United States. Why do women die despite screening? There are some cancers that even when they're found small on mammography and screening, they've already spread to lymph nodes or elsewhere in the body, and we really can't do much to prevent that. There are, however, another 10% of deaths due to interval cancers that are found because of symptoms after a normal screen and in the interval before the next screening mammogram. Most of those interval cancers occur in women with dense breasts. Here's a nice example of a small cancer in a breast that is relatively fatty, the gray tissue being the fat. It's easy to see this small cancer in a fatty breast. Unfortunately, in a denser breast, the glandular tissue, the fibroglandular tissue, is white, and so is the cancer. And in this case, this is a much larger cancer that is still hard to see because it is hidden, masked by the dense tissue. And the only reason we see it at all is because it's at the edge of the tissue. There are 4 categories of breast density that are used on the mammogram report. Category A is almost entirely fatty. B is scattered fibroglandular density. C is heterogeneously dense, which could obscure detection of small masses. And D is extremely dense, which lowers the sensitivity of mammography. These categories are defined by the BI-RADS terminology that was issued by the American College of Radiology in conjunction with experts in the field. Here are examples of fatty, scattered, heterogeneously dense, and extremely dense breasts. And again, as if a small cancer is present in a denser breast, it is much harder to see. These are the words that will be in the mammogram report that is sent to your physician, and they also may be in the results letter sent to you depending on where you live. Here's an example of 4 breasts with the differing densities that each have cancer. Again, in the fatty breast, it's easy to see. In the Scattered fibroglandular density, it's relatively easy to see. Heterogeneously dense breast, it's only seen because there's some associated distortion. And in the extremely dense breast, it's very difficult to see this rather large cancer that is visible at the edge of the breast tissue. And here are the corresponding CC views on those same patients. The red circles show the cancers on those CC views. Here is an unfortunate patient from our own practice recently who had dense breasts, and there was no cancer seen. She had pain in her upper outer right breast, which was unremarkable on ultrasound and mammography, and usually is not related to the cancer. But 6 months later, she had a palpable mass in the lower right breast, lower outer right breast, and you can see an irregular mass on ultrasound with some vascularity inside it. And also on MRI, this was a very large cancer, unfortunately, a grade 3 triple negative invasive ductal cancer that was already 9.5 centimeters at the time of diagnosis. We do see some cancers on mammography, even in dense breasts. Mammography is not worthless. About half of cancers have calcifications, and we do see those well. These are these little white specks, and they show up very nicely even in dense breasts. This was a case of high-grade DCIS with microinvasion. But about half of cancers do not have calcifications, and those are the ones that can be masked. And as a result, the sensitivity of mammography to detecting cancer is as low as about 60% in extremely dense breasts, and it's highest in fatty breasts. It's common to have dense breasts. It's normal to have dense breasts. About 43% of women have dense breasts, and dense, by dense, we mean either heterogeneously dense or extremely dense. You can see that it's less common to have extremely dense breasts, with only 7% of women falling into that category. Breast density generally decreases as we get older, but if you have extremely dense breasts, they're likely to be extremely dense throughout your whole lifetime. Some women with heterogeneously dense breasts will have a decrease in density around menopause, and it will get easier to see the tissue on mammography. Breast density also increases the risk of developing breast cancer. The denser the breast, the greater the risk. It's on average about 4 to 6 times higher risk that one would develop breast cancer in an extremely dense breast compared to a fatty breast. There also are more false positive callbacks in women with dense breasts and more interval cancers. And again, these are the cancers detected because of symptoms after a normal screening mammogram and in the interval before the next screen. And it's as frequent as 13 to 18 times more likely to have an interval cancer in a dense breast than in a fatty breast. How do you know if you have dense breasts? Well, it's really a mammographic diagnosis, and it's something that would be in the mammogram report. The results letter that is sent to you with your mammogram results may or may not describe your breast density. It depends on which state you live in. Ultimately, there should be a national standard coming soon in the United States, and in many countries, this is not included, unfortunately, in the letter that is given to patients. There are several options to improve cancer detection in dense breasts. The first of these that I want to discuss is 3D mammography, which is also known as tomosynthesis. And there are several benefits to tomosynthesis. There is a small improvement in cancer detection. And certainly when we see a cancer, we're more certain that we're seeing a cancer. They're easier to see. It's also easier to recognize normal tissue that's overlapping. So there are fewer false positive recalls for normal tissue. And it is becoming widely available and standard, at least in the United States. The cons to tomosynthesis are that there is a somewhat higher radiation dose, especially at centers that do tomosynthesis in combination with a standard 2D mammogram. It's about 2 times the radiation dose. And unfortunately, in the densest breasts and extremely dense breast, cancers are still hidden even on tomosynthesis. Tomosynthesis is performed with a series of low-dose images over an arc as the tube moves over your breast. And the result is that we can reconstruct thin, usually 1 millimeter slices that separate areas of the tissue, and in this case, make it much easier to see a cancer. Here's a nice example from Betty Rafferty's work. She was one of the pioneers in this area, with Dan Copans showing dense breast tissue. Here is a mass that's hard to see on the standard 2D mammogram, but on tomosynthesis, the spiculated mass with distortion shows up very nicely. This is a good example of the benefits and limitations of tomosynthesis, however. This woman was 40 years old and had a lump in her right breast after falling off a bicycle. And on the tomosynthesis slices, we can see one small oval mass, which actually doesn't look particularly concerning, but that's really all that was visible on tomosynthesis. On ultrasound, here is that oval mass. It's actually a little bit more lobulated in the second projection. And on further look, there actually are at least 3 irregular hypoechoic masses on ultrasound. And unfortunately, this was all grade 3 invasive ductal carcinoma. It was very difficult to see on the mammogram, even with tomosynthesis, and this was triple positive disease. And on MRI, there was even more disease that wasn't appreciated on ultrasound. It's very easy to see because of the contrast enhancement. So in summary, 3D mammography or tomosynthesis reduces false positive recalls, but unfortunately does not significantly improve cancer detection in extremely dense breasts. There are other options for supplemental screening that we add to the mammogram. The mammogram is still the standard of care in most situations. We can do screening ultrasound, we can do molecular breast imaging, MRI, or contrast-enhanced mammography. Ultrasound, many of you are familiar with, uses usually a handheld transducer with just gentle pressure. There's no injection of any material into your vein or breast. It does not use any ionizing radiation, and it's easy to guide biopsy of any findings that we see with ultrasound. It has been shown to reduce the rate of interval cancers when done in screening in combination with the mammogram, and those cancers are mostly invasive cancers that we do want to find, with a cancer detection rate usually of about 2 to 3 per thousand after mammography. And that includes after tomosynthesis in the studies to date. Ultrasound is also widely available and relatively inexpensive. Unfortunately, ultrasound does prompt biopsy for benign findings, not infrequently. This is especially true with the first screening ultrasound and is less of an issue with subsequent annual screens, but about 2 to 5% of patients may experience a biopsy for a benign finding on screening ultrasound, at least the first time. Quality can be an issue, and there is a need for national standardized training that has not yet really been widely implemented. We did develop standardized criteria with the ACRIN 6666 trial, and those are available for review. Here's an example of a patient with extremely dense breasts who's participating in an ongoing screening study that I'm doing now. You can see in retrospect there is a portion of a dense node in her left axilla, but there's nothing else visible on the mammogram or on tomosynthesis, even in retrospect. She had a screening ultrasound done, and there was an irregular mass that was 1.9 centimeter grade 2 invasive ductal cancer, ER positive, HER2 positive, and node positive, unfortunately, but she did have a complete response to primary chemotherapy with no residual tumor. Here's another patient who had screening ultrasound as part of our study. There was subtle distortion in retrospect on the tomosynthesis, but very difficult to see even knowing something was there. On ultrasound, there was a subtle, indistinctly marginated mass that was blending in with the tissue in one of the planes, but was recognized as suspicious and biopsied, and this was a grade 1 invasive lobular carcinoma. Invasive lobular carcinomas tend to be difficult to see on mammography, and often are overrepresented among cancers that we see only on ultrasound. Automated breast ultrasound is another option, uses a large footprint transducer, usually 15 centimeter, and acquires really up to about 1,000 images of each breast. It takes a while to review these images, and we don't get quite as much information. There is a reconstruction in the sagittal plane, and we don't have Doppler imaging, so most findings that need further evaluation have to undergo a targeted ultrasound to really characterize them fully. Molecular breast imaging is another option, and this is being used widely by the Mayo clinics across the country. They have pioneered this approach. This uses two detectors that are on either side of the breast. It requires an intravenous injection of radioisotope, a technetium-99m sestamibi, which had initially been used in cardiac imaging. It takes about 10 minutes per view to acquire the image, and that means a total exam time of about 40 minutes. This does improve cancer detection more than ultrasound, about 7 to 8 cancers per 1,000, but this is not widely available and does incur whole body radiation exposure. Here is an example from the Mayo Clinic experience, a patient who has relatively dense tissue, and nothing was recognized on the mammogram, but on the molecular imaging, you can see very easily the uptake of tracer in this 17 millimeter invasive ductal carcinoma with DCIS. Contrast-enhanced MRI, of course, does require lying on your belly with the breasts hanging into the coils. You are in a tunnel, and so some women have trouble with claustrophobia. Some pacemakers and other metal implants are problematic for MRI that cause artifact or other issues. It is an expensive test, and it does require intravenous contrast, and the gadolinium is known to accumulate in the brain, although that has unknown effects in the long term, and it may not have any real downstream effects, but it has been observed and is a question out there at this time. MRI does produce the highest additional cancer detection of all of the supplemental technologies at this point, of 10 to 16 cancers per 1,000 women, at least in the first round of screening, probably closer to 7 to 8 in the second and subsequent rounds of screening. There's no ionizing radiation, and it has been shown to reduce the rate of interval cancers as well as the rate of late-stage disease, and it allows us to evaluate axillary lymph nodes at the same screening exam. Here's a patient who had multi-modality imaging. I think it's nice to compare across the imaging. She had extremely dense breasts, and on the mammogram there were some calcifications that were noted. And contrast-enhanced mammogram, and I'll talk more about that, you can see very similar positioning to the regular mammogram, and in this case, the iodinated contrast that's injected intravenously is taken up dramatically in the cancer. Very easy to see this. On ultrasound, the cancer was visible as a hypoechoic mass with echogenic calcifications, and it was biopsied under ultrasound guidance. Here on molecular imaging, it also shows uptake of the sestamibi. You can see that we lose a little bit of the extreme posterior tissues compared to the mammogram. And on contrast-enhanced MRI, you can see this it's very easy to see this enhancing irregular mass. And this was a 3 centimeter triple negative invasive ductal carcinoma. She had a partial response to primary chemotherapy and negative nodes. There have been several large studies evaluating MRI in women with dense breasts. One of those that's ongoing is in the Netherlands, where women with extremely dense breasts are invited to have screening MRI after a negative 2D mammogram. And then they have had 2 rounds of screening with mammography and then MRI every 2 years. The results from the first screening round have been published, and they found a cancer detection rate, and this is after a negative mammogram. MRI still found 16.5 cancers per 1,000 women screened. Mammogram alone finds about 5 to 7 cancers per 1,000 women screened. So this is quite a dramatic improvement in cancer detection, and the vast majority of the cancers found are node negative. False positive rate was acceptable at 80 per thousand, about 8%. Christiane Kuhl has done a lot of the pioneering work on screening MRI and actually looked at screening average risk women who had no other risk factors for breast cancer. 89% of them had a screening ultrasound in addition to the mammogram that was negative, and they still found 15.5 cancers per 1,000 women screened. And again, most of the cancers were invasive with a small size and node negative, the types of cancers that we need to find with screening in order to reduce breast cancer deaths. Here's an example from Christiane's colleague, Simone Schrading. Woman does not have even dense breasts, no risk factors, she has scattered fibroglandular density, but nothing is seen on the mammogram even in retrospect. Here on the MRI, there was a small 9 millimeter triple negative high-grade invasive ductal carcinoma. Why don't we screen everyone with an MRI? Well, it is an expensive examination. It's not, there is not an unlimited supply of equipment or personnel. It is a limited resource. It requires injection of contrast. It's not well tolerated by every woman. And we do have to check renal function, kidney function, especially over the age of 60, or if there's a history of hypertension or other risk factors for kidney disease. As I mentioned, it's not compatible with pacemakers or other metal implants, and gadolinium does accumulate in regions of the brain. There is an option, again, that Christiane Kuhl has piloted and promoted, and now there's been a multi-center trial evaluating this, to reduce the time that it takes to do an MRI exam to make it more available and easier to tolerate. The so-called mini or fast MRI does still require contrast. It uses only one pre and one post contrast series and an optional T2 or water sensitive sequence. It takes only about 10 minutes instead of about 25 to 40 minutes in the scanner, which makes it more available and less expensive. But at present, there is no CPT code for insurance billing. Many facilities are starting to develop mechanisms to offer this to patients with direct-to-patient billing, usually on the order of $300 to $500. University of Pennsylvania in particular has pioneered this approach. Here's an example of a mini MRI. The mammogram is on the left with heterogeneously dense parenchyma, and you can see this small enhancing mass on MRI that was a 6 millimeter grade 1 invasive ductal carcinoma with negative nodes. Contrast-enhanced mammography is the last option I want to discuss. This is mostly being done as part of research at this time, but it is becoming more and more available. This would be an option for women who cannot tolerate an MRI, and in the ACRIN 6666 trial, we actually found that 42% of women didn't want to have an MRI even when provided at no cost, and nearly 1 in 5 women who could have the MRI in principle were unable to for medical reasons. So it is nice to have an option instead of MRI, and it gives us similar results to date. It requires an intravenous injection, but this time the contrast, instead of being gadolinium, is iodinated contrast, the same that's used in CT scanning. It does produce a warm feeling all over, and you get a metallic taste in your mouth that usually goes away in about 20 seconds. There is a small risk of contrast reaction. Usually it's a mild, very self-limited reaction of hives, maybe a little runny nose or something like that, less than 1% of women on average. If there is a contrast reaction that's more serious, the medical team is trained to address that. It does use the same positioning as mammography. There are 2 exposures, though, one at a lower energy and one at a higher energy. And in so doing, you can subtract the low energy from the high energy image and see just where the iodine is going. In other words, what's enhancing within the breast. And cancers will enhance because of abnormal vessels, just like they do on MRI. The radiation is about twice that of a standard mammogram. Here is an example, a patient with extremely dense breasts. She was actually participating in the tomosynthesis versus ultrasound study that we were running, and we found a very, very subtle area of distortion on the tomosynthesis, and this prompted ultrasound directed to that area, which showed an irregular hypoechoic mass. On contrast-enhanced mammogram prior to biopsy, you can see very easily, like a light bulb, the brightly enhancing irregular mass that was a 1.3 centimeter grade 2 invasive ductal carcinoma with DCIS that was ER/PR positive, HER2 negative, and negative sentinel nodes. The advantages to contrast-enhanced mammography are the lower cost, and it is relatively easily implemented in a breast center. The disadvantages, it does require intravenous contrast injection with a small risk of contrast reaction and that uncomfortable warm feeling for about 20 seconds, as I mentioned. But it does look like something that will be more and more promising as we go forward. To summarize the overall efficacy in terms of cancer detection and false positives across these technologies, with tomosynthesis compared to a standard digital mammogram, the added cancer yield is just under 2 per thousand. Ultrasound adds another 2 to almost 3 per thousand even after tomosynthesis. Molecular breast imaging is about 8 per thousand in the current studies, and MRI after tomosynthesis is about 10 per thousand in the studies to date. Contrast-enhanced mammography in different patient populations, mind you, about 11 per thousand, so very similar to MRI. In terms of false positives, the tomosynthesis does reduce false positives, as I mentioned. Ultrasound, there's an increase in callbacks, which is usually short-term follow-up or biopsy rather than immediate additional testing, with the exception of the automated ultrasound, but about 100 women, about 10% will be called back because of ultrasound. MBI, it's about 6 to 7%. MRI after tomosynthesis, to date, the callback rates are high, but this is greatly lowered in the second and subsequent years, just as it is for the other technologies. Contrast-enhanced mammography may be a slightly lower recall rate or false positive rate compared to MRI, but we need larger prospective studies to really say that with certainty. We do know that we have seen reduced breast cancer mortality. And again, just to summarize, and this is from the article in the AJR that was published in electronic form in September of 2020. If we look at the big picture, we want to start with a consideration of genetic testing by age 30 to help us identify high-risk women, or at least go through risk factors. If we do find the woman to be at high risk, then she should start annual MRI only at age 25 to 29. After age 30, we want to add mammography. If she has a personal history of breast cancer, I did not discuss this in detail, but there are now guidelines from the American College of Radiology, at least, to recommend screening MRI be done in women who have a personal history of breast cancer and were diagnosed by age 50, or who have dense breasts. Also, women who have a high-risk history of lobular carcinoma in situ or prior atypical biopsy can be considered high risk for MRI. Prior chest radiation therapy by age 30 and at least 8 years earlier creates a high-risk situation for breast cancer. And finally, women who have family history that's worrisome enough to be seen for evaluation can undergo formal risk assessment, and if lifetime risk is found to be at least 20 to 25% by models such as Tyrer-Cuzick, Bodicea, Penn, or other models that look at family history in detail, then that also is sufficient for current criteria for MRI. And there should also be an annual mammogram in these situations. However, even in the highest risk women, we want to stop MRI by age 75. In the rest of the women who are not found to be high risk, we want to start screening by age 40, and I mentioned that's especially important in women who are Hispanic, Black, or Asian. We want to obtain a baseline mammogram and look at the breast density. We can then consider adding additional screening with MRI if it's available, or screening ultrasound, especially if the breast tissue is extremely dense, and ultimately contrast-enhanced mammography and molecular breast imaging are options at some centers at this time and may become more widespread options in the future. It is important to reassess risks as well as density every year because these things can change. If a woman does not have dense breasts, then annual mammography or tomosynthesis alone should be sufficient if she's not high risk and does not have dense breasts. One other factor to consider is if a woman has a family history of breast cancer but doesn't meet formal high-risk criteria, that you may want to start screening mammography 10 years prior to the age of diagnosis of that closest relative, but not before age 30 in any event. I just wanted to close with my own story, then my own motivation for doing even more outreach and efforts in this area. Like over 300,000 women in the United States each year, I personally have experienced breast cancer. I have dense breasts. I have a family history of breast cancer. My mother had it at 55, my paternal aunt at age 40, and then again at age 60, and died from it the second time. And because of my family history and putting myself into the Tyrer-Cuzick risk model, and finding that my lifetime risk was 20%, I asked my doctor to order an MRI. And on the MRI only, but not even in retrospect on the mammogram, I could see a small cancer. It was less than a centimeter. It was grade 1 invasive ductal cancer with negative nodes. It was easily treated. To me, this is the progress. This is the reason that we want other women to be aware, to be able to advocate for themselves. And it was because of my own experience, and here's my cancer on ultrasound as well. This prompted me to work with the advocate Joanne Pushkin and technologist Cindy Henke to develop the website densebreastinfo.org so that other women can be educated about their breast density and about their options for supplemental screening. Thank you so much for your attention. I hope this was helpful. If you have questions, it's probably easiest actually to send them to the website and we will get back to you. Thank you so much.